as was mentioned, the MR with the Impella, I want to invite Dr. Joyce Wald to speak with us about acute MR with severe pulmonary edema on Impella,
Exactly.
assessing the right ventricle. So it was a perfect segue.
Perfect segue. So thank you everyone for staying, and thank you to all my friends on the panel. So let's talk a little bit about acute MR and pulmonary edema on the Impella 5.5. So first, what does acute MR look like in comparison to chronic MR? So we know that patients with chronic MR, the LA has time to dilate, and the lungs kind of over time get accustomed to this higher pressure. Whereas with acute MR, that left atrium does not have time to dilate and to get accustomed to that large volume. So it's more like a fire hose, pose for my picture, on the lungs, right? And so the lungs get blasted with volume, and then the RV takes a hit. And you can see here on this slide the different, which all of you guys know, the different causes of acute mitral regurgitation. It can be a papillary muscle rupture, it can be endocarditis, it could be Takotsubo's. And you can see here, what would ECMO do to acute MR? So we know from a lot of the volume loops that we have seen earlier today that ECMO is a high afterload state. So in theory, it can make that acute MR worse and load the lungs even more. And this is actually an interesting case that I found when preparing for this talk of what else could potentially cause acute MR on Impella 5.5 support. And this was actually a case report of where the Impella inlet actually interacted significantly with the mitral valve apparatus and led to a ruptured papillary muscle. So something to consider. We're up to 254 pumps and still have never seen this, even when it's rotated towards the mitral valve. But there is a case report out there. And as my friend Jim always says, the enemy of good is perfect. So we get called all the time because the manual tells us that the Impella 5.5 should be 5 centimeters deep from the aortic valve. And we get called because it's measured. This is measured at 5.89, but it's right mid-ventricle. It's a giant ventricle. It's fine. This is one that's read at over 7 centimeters deep, and yes, it might be a little bit deep, but when you actually play the video, it's dead center in the ventricle, and the position is fine. So I think the takeaway from this is that, yes, sometimes it looks like it might be interacting with the mitral apparatus, but most of the time it's not, and that you have to also just make sure you're looking at it in multiple views. Also, what I didn't include in that last slide was we are going to present at ASIO our small ventricle series. So there was a lot of hesitation to put Impella 5.5 in a small ventricle because of that data on HeartMate 3. But what Andrew Acker, one of my residents, is going to present is that the outcomes were equivalent, but that we just keep it shallow. So again, that 5 centimeter measurement might fly out the window for some of our patients. This is another kind of unique presentation of pulmonary edema in a patient with an Impella 5.5. So this was very early on in when we were doing Impella 5.5s in our hospital, and you can see on the left that it's reading suction, right? And the aortic placement signal is reading hypotensive. But if you really look over to the blood pressure, what it really is, it's fine. It's 104/56. But unfortunately, they blasted this patient with volume, thinking they were hypotensive and there was suction, but in reality, there was just optical drift. So this was an iatrogenic cause of pulmonary edema with Impella 5.5 due to a false suction alarm in the setting of optical drift. So in our center, because we put our Impella 5.5s down on the floor in the step-down unit, we have taught them that if the aortic placement signal is more than 10 millimeters off of their manual blood pressure cuff, to recalibrate it. And so how does Impella 5.5 affect RV hemodynamics? So this was an abstract that was presented a couple years ago by my then resident, James Schur, and what he looked at was our 11 patients who required upgrade to biventricular support, and for us it was Impella, and then compared them to the same era of patients, at that time 31, who did not require upgrades, so a total of 42 patients. You can see it was a pretty sick cohort of patients, Intermax 2, Sky D, and what we actually found was, in the red, the baseline right-sided hemodynamic parameters were all the same. So they all started out with the same RA pressures, RV systolic pressures, PAPIs, and VIS scores, but what we found over time was that those patients who required upgrade actually started to slip. So they started to have lower PAPIs, higher right atrial pressures, higher VIS scores, and worsening renal function. And that was a signal to us as a team to start really watching for this more closely. And we're working with a cardiogenic shock working group to try and come up with a dynamic score to see if we can then identify patients, because they're waiting for so long with Impella 5.5 while they're waiting for transplant, of who should get upgraded to biventricular support. James Hernandez did cite this paper, and this was our larger series that was published in ASIO of 150 patients, in which 17 required upgrade to Impella. And you can see that over time for the full cohort, our PAD did come down, but that in the red on the right, of those patients who required upgrade, that those patients, their RA pressures were trending towards worse and their PAPIs were trending towards lower. And this is the full cohort again, that you can see over time that they had a statistically significant decrease in PA pressures and markers of RV afterload, and a trend towards a decrease in PA means. I want to just thank my surgeons, because Maurer Biscotti coined the term ICPR, because our surgeons can get somebody on Impella 5.5 in 40 minutes without general anesthesia. And we find that a lot of times when we're not putting them under general anesthesia, we can get away with a sick sick RV and get them through without having to intubate them. So thank you.
Great job. Joyce, let me ask you right off the bat to give us sort of a sense, maybe for the audience, of this setting in, let's say, an acute MI setting versus a more chronic setting, where you might see this.
Yeah, I think we have a patient right now who was an acute anterior wall MI and is on Impella 5.5, but his LV never dilated. And he was smoking up until the time he came in, so we're going to subject this patient on Impella 5.5, unable to wean, to palliative inotropes, or are we going to kind of toss it out the window and say we're just going to ignore this, not ignore the smoking, he doesn't have the benefit of time to prove abstinence, and we're just going to transplant him. So I think we can get away with the small ventricles with the Impella 5.5. Don't be scared to do that. And it does unload the LV. It does decrease CMR. I'll show that tomorrow in our acute hemodynamic and echo findings post Impella 5.5. And I see you, Mark. You're raising your hand.
Yeah, Mark is ready.
We can get away with it with a small ventricle more so than we can with the HeartMate 3.
Yeah. Two quick comments. So I agree with you. Yeah, small ventricle is not a problem.
Yeah.
And we actually now have 5 kids, and the smallest was 12 kilos. So actually you can just put it through the innominate artery. It works easily well. It just sits in 2.5 to 3 centimeters, and it works absolutely fine. And the only issue is kids, you have to make sure that the outflow, though, is still just proximal to the innominate, so you're not just perfusing the head. But the small ventricle is not an issue, and it shouldn't stop you from using it. And then the other is, and as I our previous talk, I would modify it a little bit, saying it does an outstanding job. I would say it does a good job, and it's the best we've got. So we have data coming out now that actually all our patients that are in real shock on an Impella 5.5, not Impellas, if you look actually at neurohormonal changes, because the longer they're on actually over time, a lot of them do deteriorate and don't look good. So actually after 3 to 4 weeks, a third of them actually will have improvement in BNP, TNF-alpha, and plasma norepinephrine. A third of them slightly improve but do not normalize. And a third, although their blood pressure is the same, their creatinine improves, neurohormonally they're still in shock.
Right.
So the idea is they're not unloading the same in everybody or consistently, and you have to be very careful and watch them, because after 4 weeks, those are the ones that start to deteriorate and you're in big trouble.
Evgeny?
I think that is also a measurement problem, because comparison to HeartMate 3 and to Impella, the accuracy of the measurement. Do you believe in this measurement, the 5.5 liters, is it truly 5.5 liter? I don't know. I did not prove it because it's not possible. But what we did prove is that we measured the flow on HeartMate 3. We put the flow probe on the outflow graft intraoperatively. The standard flow probe you use for the measurement of bypasses, we have 14 millimeter probe. You can buy it at a commercially available, and the flow measured by flow probe is different to that what HeartMate 3 shows, and guess how many and which direction. Do you imagine? Can you imagine?
Can I what?
Is the flow, the real flow measured and the outflow graft, is it higher or the lower than HeartMate 3 shows?
Right, I don't know. Do you have any Abiomed engineers in the room
Mark?
We
who know this?
We've done the same as you for every new VAD. Actually, the first 10, we put a flow probe on in the operating room and actually get a new graph based off of filling pressures as well. And the HeartMate 2 was off by a liter. The HVAD was the closest. HeartMate 3 is about 80% accurate, but very clear at lower flows.
It's lower.
It is
yes,
exact the
it
same.
overestimates. And
We have
high flows, you're way off.
Yep.
And Impella, you can put it in a static loop. So you can put it in a static loop and see how much it flows. And the answer is, I mean, I know they're here and we appreciate them. It's not 5.5.
Yeah, and what I want to say, the flow differences between half a liter and 1 liter, but always higher than HeartMate 3 shows. So that means if we put the HeartMate 3 and the HeartMate 3 shows you 5 liter, unloading, it's actually probably more. So the unloading with HeartMate 3 is completely different than unloading with Impella 555.
Manesh, go to you back. So now you have Impella 5.5 and you have severe MR. How do you deal with it?
So first I want to talk about the little bit small ventricle. So small ventricle going in a 5.5, yes, there is an issue in a certain situation. ECPR, ECMO, AMI shock, entire left main and everything, you did PCI, ventricle is all, septum is very swollen, edema is too much, and they put a CP initially, and now you got an ECMO. That patient I would wait, because if you go and put a 5.5, number one, you're going to have a challenge, number one, you're going to have a lot of bleeding issue, that's we've dealt all the time, a lot of transfusion, and you're not going to get more than 1 liter continuous suction LRM, consuction LRM, so leave the CP and wait it out, and then eventually when you're ready to go, and then change it out. Now, second part about the small ventricle and AMI shock, same thing. Only time we deal with the small ventricle, a lot of patients we have mostly is AMI shock, anterior STEMI. If it's a posterior and everything, they will be fine. Now, problem with the AMI LAD one, they will dilate if you leave them 2 to 3 months, and we have those things. The apex will dilate. Base, you'll still have it. So when you go for the heart LVAD, I think you will be okay, but I would do coring first instead of just putting a ring first and then implanting, because that way you have a better your positioning to the cannula. So that part. Now regarding the MR, depends on if it's a functional MR. And I think that over time it's with the diuresis. Main thing what we see, what happens is in those patients, so many times you have those 2 months, and most of the time they take out the SWAN, patient goes to the CQ, another ICU, and only monitoring, you have a clinical monitoring. And your diuretics you cut down to now oral instead of drip. What happens, milrinone is gone, and then suddenly you have an Impella malfunction. That's what they say, it's not unloading much. When you do right heart cath, suddenly now you have a severe MR and everything. The problem is not because you cut down your diuretics and everything. and that's where it affects us a lot in the, you know.
So we'll take one question from the audience,
Go
and
ahead.
then we'll need to move to the last session.
Impella,
Microphone.
it's
Go
just a calculated flow because of the milliamperes and the rotations per minute. It's an axial flow pump compared to HeartMate 3, which is a centrifugal pump, completely different. So obviously the flow is going to be much lower than what the flow is reading in it. The second point is, if it's a Carpentier 3B, there is basically tethering of the posterior leaflets. You're never going to eliminate the MR, even if you put an Impella. And the main issue with the Impella is the impeller is basically parallel to the interventricular septum. So there is always going to be some suction. It is going to limit you, whereas durable LVADs, it's an apical cannulation. It's going to be far superior. We're going to publish the paper, basically the same Impella 5.5 residual MR compared to durable LVAD. The degree of MR reduction is far superior with the surgical LVAD compared to Impella 5.5. That's only a small subset of patient population.
Thank you for that. All right. Well, thank you very much, Joyce.